We are here to talk about the therapeutic interventions for the treatment of clients with chronic pain. We are going to talk a lot about theory and the biological aspect of it to start, and then we'll move into more interventions for chronic pain, mostly cognitive behavioral therapy and pain reprocessing therapy. And then we'll use conversations and scripts and preparatory role play sort of exercises to discuss how people in pain can share that with the people in their lives, partners, family members, providers. And so we're going to take a biopsychosocial approach to today. This is a little bit about me and my education, my experience, what grounds me in the information that we're talking about today. I am from sort of the Dutchess County, Hudson Valley area in New York, about 75 miles north of New York City. I grew up in that area. I still live in that area. I went off to Boston for undergrad, and then I went to Gallaudet University in Washington, D.C. for my doctorate in clinical psychology. So I do have a specialization in working with deaf and hard of hearing individuals. And currently in Beacon, I have a private practice called BFF Therapy, where I specialize in adolescents and young adults with anxiety and depression, many of whom do experience suicidal ideation and self-injurious behaviors. But what I have found with a lot of my clients is the somatic manifestation of their emotional experiences. And so having stomach aches, headaches, fatigue, pain. And so that coupled with my own experience with chronic pain, I pursued more specific certification in pain reprocessing therapy. So I do have advanced certification in PRT. I've worked with many sort of like tech-based applications that ties, anxiety management, chronic pain management, and technology, biofeedback with ThinkLadder and Flowly. So I can talk a little bit more about them as apps that you could use. And then I've just been featured on a bunch of different podcasts, so you can learn more about me and listen to those for more deeper understanding of some of the things we talk about today. If you have any questions, but we'll do a full, deep dive into a lot of things today. So again, I'm really appreciative for you all being here with us. Let's just start with the stats. Chronic pain affects 20% of the people in the United States, and that's associated with a related estimate annual cost of more than $600 billion. So a lot of people are experiencing pain, and the things that are tied to that, like doctor's appointments, scans, medication, injections, physical therapy, chiropractors, mental health services, it amasses quite a bill. The most common type of pain reported is chronic back pain, which you might see referred to as CBP throughout today's presentation. And per the National Health Survey, people with chronic pain reported a 22% reduction in their ability to engage in activities of daily living, things like getting out of bed, paying attention to basic hygiene, feeding themselves, just engaging in things that you would think and a lot of these individuals sort of say are expected of them, and that can be connected to a lot of embarrassment, a lot of shame, a lot of guilt, and a lot of anger and sadness too toward their pain. And that's where some mental health skills can come in handy. Also, the NHS reported a 25% reduction in social engagement. So people are maybe avoiding leaving the house, maybe avoiding conversing with other people. That could be conversing with other people from the comfort of their very own house, their couch, and a 49% reduction in work limitations. So a lot of people having a hard time engaging in work for a variety of reasons already mentioned. So this is pervasive what we're talking about. Pain impacts pretty much everything. And when we think about the definition of pain, the International Association for the Study of Pain, or the IASP, defined it initially, which was in 1979, as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of tissue damage, or both. In 2020, they revised their definition as well as expanded it, which we'll cover in the following slide. But a lot of individuals in pain psychology as a field and pain psychologists were really happy to see some revision. And this is, again, in the last 5-6 years. They changed the definition to an unpleasant sensory or emotional experience associated with or resembling that association with actual or potential tissue damage. So it changes the connection because it doesn't have to be actual or potential tissue damage itself, something I might refer to in the future as structural damage to the structure of the tissue itself or the body, but that resembling or that association with actual or potential damage. And one of the main tenets of pain reprocessing therapy is that it's really helpful for something called neuroplastic pain. And that is the experience of those sensations of pain without associated structural damage. So when there is no injury, or maybe there is an injury, but some people who have that injury experience pain and some people don't. And so, what are the biopsychosocial factors that play into that person's individual experience of pain? Maybe they had an injury, but it has since been healed. And so, there shouldn't, in theory, be pain associated with it, but they still experience that pain. That's something that we'll talk about in a bit with amputees, right? Phantom limb syndrome is a very real experience for many individuals, and that limb no longer exists. So the actual structural damage is no longer there. It's not connected to their body, but they still have this very real sensation of pain. So just something to think about as we continue on. Their expansions include that pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. So as we sort of talk about how we've come to this biopsychosocial model, this approach, there's been many theories of how an individual experiences pain, how the spinal cord and the brain communicate pain to one another and the rest of the body. And so to have the IASP acknowledge that there is an influence to that sensation from biopsycho and social factors is a really big deal, because prior, the idea that the psychological impact or the social impact might not have had an equal amount of bearing or bearing at all on the experience. You'll see that as we talk about it. So it's very cool to see that included. Also, differentiating pain and nociception, that they're different phenomena. So pain cannot be inferred solely from activity in sensory neurons. So nociception is the nervous system's processing of impending or actual tissue damage, and pain is understood as the subjective experience of harm, which we believe is impacted by biopsycho and social factors. Throughout their life experience, individuals learn the concept of pain. A person's report of an experience of pain should be respected. And I think that's amazing that they have that there. I think that's will forever be a work in progress. And that even if really well-intentioned, some statements might come across as invalidating to individuals in pain, but to have that in the expansion is fantastic. Although pain usually serves an adaptive role, it may have adverse effects on function, as well as social and psychological well-being. And the verbal description is only one of several behaviors to express pain. Therefore, the inability to communicate does not negate the possibility that a human or non-human animal experiences pain. And that comes in handy when I think about younger individuals who may not have the language to communicate pain. I also work with some nonverbal individuals. So without having the verbal description does not then mean that there's no experience of discomfort. So I think all of these expansions are really fantastic, and we're moving in a great direction, as we have been over, hundreds of years. So when we think about the earliest theories of pain, it was believed to be the consequence of committing immoral acts, and that the suffering that an individual in pain endured was their way to repent. One of the first alternative scientific pain theories was introduced by French philosopher René Descartes in 1644. He had hypothesized that pain could be a result of physical injury or psychological injury, but they did not influence one another, making pain a mutually exclusive phenomenon. That does fail to explain why no two chronic pain patients have the same experience with pain, even if they have similar injuries. So we can sort of explain that away. When we think about the specificity theory of pain, in 1811, Charles Bell, he believed that the brain was not the homogeneous object that Descartes believed that it was, but described it as a more complex structure with various components. Johann Muller concluded that there was an infinite number of receptors in the skin, and that this surplus of receptors that we have, sort of like covering our skin, accounted for the ability of an individual to discriminate between different sensations. In the late 1800s, Maximilian von Frey made a critical addition to that theory with the discovery of four separate somatosensory modalities found throughout the body. So he classified all of those surpluses of receptors in four groupings: cold, pain, heat, and touch. So like pressure. Unfortunately, that still fails to account for factors other than those of physical nature that result in the sensation of pain. So the context that we're receiving, the moods that we're in, our social surroundings, and also lacks an explanation for why sometimes pain does persist long after the healing of an initial injury. So if it's solely dependent on the receptors, then how does that explain neuroplastic pain, which is pain that persists well after an injury has healed? In 1929, there was an American psychologist, John Paul Naef. He indicated that there were not separate sensory receptors for each of the four modalities, so directly in opposition to the idea suggested in specificity theory. So he suggested the pattern theory of pain. He suggested that each sensation relays a specific pattern or sequence of signals to the brain. And the brain takes this pattern, deciphers it, and then the pattern the brain reads correlates with the sensations felt. So it's not necessarily the receptors themselves, but the pattern that's communicated between the spinal cord and the brain that communicates how the sensation should be experienced by the person in discomfort. It can be stated, though, with certainty that this theory is an inaccurate explanation for how we feel pain, given that there has since been discovery of unique receptors for each type of sensation. So that's what he is directly opposing in specificity theory, but we have found that there are specific groupings of receptors for each sensation that help communicate through our central nervous system those sensations to us and how we feel them. Then we have the gate control theory, which I think a lot of individuals in this field still lean on heavily as sort of like the origin of where we are today. That's through researchers Ronald Melsack and Patrick Wall. They proposed that we view pain through a mind-body perspective. That was in 1965. They started this idea that pain was not solely the result of physical injury, but really a complex experience that also included the influence of cognitive and emotional factors. So we're starting to see this biopsychosocial approach emerging at this time. It proposed that neurological gateways in our brains decide which pain signals get to come through and which are kept out. So when we're thinking about like literal gates, the definition is that the sensations of a noxious stimuli, so those are threatening to the body, things like pinching, exposure to an irritant, extreme temperature, like extreme cold, extreme heat. Those sensations can be blocked by something not threatening to the body or a non-noxious stimuli, which is carried by nerve fibers that reach the brain before painful input because those nerve fibers are slower. So I know that's a mouthful. We will talk on the next slide about nerve fibers and how the speed or pace of information, how that travels, which will help make more sense of gate control theory. But just thinking about what a regular gate does, right? It creates a barrier between what's allowed and what stays out. If the gate is open because of the information that's communicated through these nerve fibers, then there's increased pain sensation. And if we have closed the gates, which the speed of these nerve fibers and our knowledge about pain neuroscience allows us to do, then we can limit or minimize the amount, the frequency, the duration of these painful and uncomfortable sensations. So let's talk a little bit about large versus small fibers. So when we think about large nerve fibers, they send your brain information about things like being touched or feeling pressure on your skin. So when we think about those types of experiences and those types of actions and large nerve fibers, we think about messages being sent really quickly. Small nerve fibers send your brain information about pain and really intense extreme temperature. So large nerve fibers are non-noxious stimuli, and small nerve fibers are communicating noxious or threatening stimuli. Those messages are sent more slowly. So, the body and the brain do what they do best. They're trying to protect us with the information that they have. And so the nerve fibers are slowing down the communication of those noxious, more dangerous, more threatening stimuli. And they're using their large nerve fiber sort of communication road to send sensations like being touched very softly or more surface level, or pressure on your skin, but not in a painful way. So increasing that large fiber activity helps a person perceive pain as being less than. And because it's getting to the brain first, it helps close the gates. So this explains why something like rubbing your knee, if you think about a little kiddo, falling and scraping their leg and like holding their knee or having someone like blow on it to feel better, that actually does reduce the experience of those painful sensations because the blowing on it or the holding of it or the rubbing of you hit your funny bone, you grab your foot, if you stub your toe, that pressure, just that touch sensation is being communicated through those large nerve fibers, and that's being sent to your brain much more quickly than the painful experience of the falling down, the cutting up of your knee, the clutching of your stub toe or your elbow. Someone said, does the large fiber sensation need to be in the same body area for that to work? No, not necessarily. It can. I think naturally, a lot of people do tend to grab the area that is hurt because their attention is just sort of naturally drawn to, I stubbed my toe, my attention is on my toe. So I'm going to pick up my foot and hold my foot, or oh, I bumped my elbow, I hit my funny bone, I'm just going to grab that. But it doesn't necessarily need to. So that's where when you're not feeling good, there's science behind having a hug, right? Just having a little bit of touch or pressure on your skin, or having someone hold your hand when you're not feeling good or you're in pain. Those feelings, those sensations are being communicated through large nerve fibers, and they're being transmitted through the spinal cord to your brain much more quickly. And if we're thinking about gate control theory, we're thinking not only does that sort of speed through, but it's closing a gate. So it's preventing even the passage of those more threatening, dangerous stimuli that are coming through on large nerve fibers. But yeah, it's pretty cool when you think about it. I think we do these things. I certainly had no idea before I started really learning about pain neuroscience that the things I was naturally doing and had sort of been raised to do socially were really grounded in science. And that's what I think is really cool about the biopsychosocial model is that it sort of provides some psychoeducation on these things. So we're rooted in more science. And I'll talk, there's some mention throughout the PowerPoint that even if it's a little bit, some of the explanations of these things to your clients and having a little bit of pain science knowledge, that alone can reduce their experience of discomfort and painful sensations, but it is most effective when combined with psychological and social interventions as well. So back to phantom limb pain, which I think is so fascinating and really for me, as a learner of this information, but also as a communicator of this information, really helps drive home the idea of neuroplastic pain because it can feel foreign to like connect the idea of feeling very real physical and painful sensations associated with a body part or a perceived injury that doesn't exist, like the structure itself with someone who has all their limbs intact, there's no injury, or there might be a disc bulge in your back or herniation or some inflammation, but in theory, that image itself shouldn't be uh, associated with the level of the amount of the frequency, the duration of pain that that individual is experiencing. But when we have someone who is experiencing pain connected to a limb that's no longer there, there's no structural damage because there's no structure. I think that really sort of drives the point home. I see someone asking if the slides will be available for the training. The slides will be sent after the training. So you will have a copy of the slides afterward. So when we think about the neuromatrix theory of pain, I like this one because of the phantom limb basis, but also because it really relates to my experience with somatic manifestations of emotional pain in my clients, especially with clients who are experiencing trauma or have diagnoses of PTSD. So Melzak's exposure to amputees that were experiencing phantom limb pain in well-healed areas sort of prompted this inquiry into how he might revise his philosophy of pain. And so he defined this neural matrix of multiple areas within the central nervous system, so again, spinal cord and brain, that contribute to the signal that's sent, which allows for the feeling of pain. And the signal that these areas of the CNS work together to create is responsible for that individual's experience of pain. And he referred to it as the neurosignature. The idea that peripheral signals can alter the neurosignature highlights the effect of the psycho and social factors, those non-physical factors on an individual's experience of pain. So again, we're starting to see with gate control theory, with the neuromatrix theory of pain, sort of this multi-step approach encompassing all three of these aspects of a person's experience with pain. And he claimed that when there was an alteration in a certain signal, it allowed for the memory formation of those particular experiences. So if the same circumstances occurred again in the future, the memory or the neurosignature itself would allow for the same sensations to be felt. And that's where I connect really deeply with my clients who have experienced trauma. Because when I think about flashbacks, or just general nervous system dysregulation, even if they're not having a visual memory or like an auditory memory, just all of a sudden starting to feel overwhelmed. That might be when they're thinking about, one of the senses, the sounds, the individuals, the time of day, the smells, what they were looking at, like tied to that trauma. even perceiving that cognitively can sort of dysregulate their nervous system. But if they find themselves like close to a person that was involved or in the setting where it took place, they are experiencing those same sensations that they felt perhaps when they were in that original trauma. And so I do like a lot of the things we talk about today, not just in therapeutic interventions for chronic pain, but really for interventions with my clients who are experiencing depression and anxiety or PTSD. It still does fail to account for social constructs of pain, but I feel like at this point, we're moving in the right direction. So, how did we get here? George Engel worked to reverse what he describes as the dehumanization of medicine and disempowerment of patients, what I just think of as like the purely medical model. So, identified patients, not necessarily clients. He offered a holistic alternative to this biomedical model that had at that time really dominated industrialized society since the mid 20th century. And this multi-pronged approach is really a way of understanding how illness and suffering are affected by multiple levels of organization. Practically, it's a way of understanding a client's subjective experience as an essential contributor to diagnosis, health outcomes, and really just humane care. Those psychosocial variables are important determinants of an individual's susceptibility or predisposition, the severity, and the course of the illness than had been previously appreciated by those who maintain purely a biomedical view of illness. So, as clinicians assessing with more time, attention, and care than maybe medical professionals do, whether that's restricted by their education, what they value as priority, the time that they have with their clients, the restrictions or parameters that they're sort of reduced within, if they're using insurance, which I know we sometimes have to manage, but noticing that a person's family history, that their psychological experiences, their personality traits, how they might impact how a person both perceives, attends to, and experiences just sensations of discomfort that might have been overlooked or ignored by the biomedical model in the past. So, anesthesiologist Dr. John Lozer has been credited as the first person to use the three-prong model in association with pain. He suggested that 4 elements need to be taken into consideration when evaluating a patient with pain. So, nociception, as I mentioned earlier, that's the signal sent to the brain from the periphery, like from the skin sensors, to alert the body that there's some degree of injury or tissue damage. Pain is the subjective experience that occurs after the brain has processed that nociceptive or biological input. And then suffering is an individual's emotional response to the nociceptive signals, and that pain behaviors, so that's number 4, are the actions that people carry out in response to the experience of pain. So when we break them down, when we think of biology, we're asking about genetics, tissue damage. We're paying attention to things like hormone levels, diet, sleep hygiene, a lot of predisposing factors, things that in theory the biomedical model is asking about. As clinicians, again, we might have a more opportunity to spend weekly meetings with them, ask about their sleep hygiene, work with them on improving their sleep hygiene, do a little trial and error, see what helps with that. Same thing with diet. But as much as we can say that the biomedical model in its, purity is maybe not the best approach, I also don't want to encourage like a siloed psychological model. I think it's really important that we as providers are collaborating with one another, because I'm always going to be encouraging, if they haven't already, which typically they're coming to me sort of last on the list of providers they're going to, orthopedists, rheumatologists, pain management providers, physical therapists, chiropractors, maybe acupuncturists. And then someone might suggest, like, oh, have you considered therapeutic intervention for chronic pain? Like, there's a stigma of leaning into this idea of, oh, it's all in your head. Maybe some therapeutic techniques could be helpful, but sending them for scans and blood work and checking their hormone levels and seeing what the structural tissue looks like. And that allows me to better tailor my psychoeducation, the ways that I might do my assessment with them, the ways that I get their buy-in for a model like pain reprocessing therapy. So I really value collaboration. And I do find that as the field of pain psychology expands, there is more integration and focus on pain management in general, but also through a therapeutic lens being pushed into medical schools. And so the people that are, being raised in the field now are also being encouraged to collaborate with us. So I really look forward to a future where we're all sort of on the same playing field and working with one another to best support the needs and what's in the best interest of our clients. But obviously, our home-based psychological impacts, thoughts, beliefs, biases, coping skills or lack thereof, and then the social aspect. Who's their social support? Do they have a social network? What are their hobbies, their culture, their religion, their socioeconomic status? All of that is going to impact their experience of pain, their experience of treatment, their experience of treatment in the past, their experience of active treatment as they come into you, and their willingness to engage in certain forms of treatment in the future. So in addition to better outcomes and increased patient satisfaction, this three-pronged approach does serve to reduce the financial costs, that $600 billion amount, right, associated with caring for chronic pain patients. Research comparing an interprofessional biopsychosocial pain management protocol to alternative methods concluded that the former is 21 times more cost-effective when compared to other methods. This reduction in the cost can be attributed to the decreased need for pain medication, reduced calls for healthcare and emergency room visits, and decreased disability payments. So we're seeing a significant impact on an individual's life across domains, which then translates to the need for less additional supports, which in turn sort of prevents them from having to spend so much money on care. Let's talk a little bit about the central nervous system. We've started to. When we think about the CNS, right, the brain and the spinal cord, it's that the body's receptors send that sensory information from you through the spinal cord up to your brain, and that information can be interpreted as safe or dangerous. So we've got an interplay of bio and psycho here. If you believe that you're in danger, your brain will do what it does best. It will protect you by communicating pain. So imagine if I were to toss you a baseball, right? But your brain thought it was a grenade, you'd respond as if it were dangerous, even though it were safe. You wouldn't hold your hand out to catch it. You'd probably hold your hand in front of you to protect yourself. You'd duck, you'd dip, you'd run. So this is a good metaphor, which I use a lot with clients, to explain that pain and these uncomfortable sensations are not necessarily accurate indicators of tissue or structural damage, but rather our brain's best guess based on the information available. So I use this example with my clients a lot, and I always put it in trainings about chronic pain, and hopefully you all each have your own sort of version of this that you might be able to turn into a metaphor when you're explaining the central nervous system and our neural pathways and how we sort of carve them into more sturdy, centralized pathways that are taken sort of to communicate information from the periphery up to our brain and back. but I use tap dancing. So I always tell my clients, that I started tap dancing when I was really little, like 3 or 4, and I was in a combo class, and it was pretty basic, but I had a really hard time keeping up. I had a hard time going across the floor. I couldn't learn at the same rate as other kids in my class, but I really enjoyed it. So I was able to like have my teacher come in a little bit before class or a little bit after just to work some extra with me. And I started practicing, and that extra time started really carving these neural pathways in my brain for tap dancing. It got really strong. I started meeting for proper habits. Then I started taking additional tap classes, and eventually I like was in the advanced tap class when I was 11, and I was tap dancing in the city, and I was in multiple professional tap companies as a young adult. And so practice makes perfect. That's not a phrase that's probably uncommon for most of your clients. They've probably heard that before. And so just like I became really skilled at tap dancing, and you might have become really skilled at one of your hobbies or something you're really passionate about, the brain can also become really skilled at pain. And persistent pain is practiced pain. So those neural pathways, they strengthen. And I use sort of like a paved road example when I talk about neural pathways. So when I think of a practiced neural pathway, a persistent pain pathway, that's a paved road that's got those brand new, bright green, luminescent signs. There's lights everywhere. There's no rocks. Everything is lined perfectly. Like it's smooth transition onto the road, and you can just follow that road as long as you want. Some of those other neural pathways that we might want to like start practicing when we think about the therapeutic interventions that we're using, I think of those roads as sort of gravelly, potholed signs that are sort of darker or painted over or knocked over, harder to see. Maybe there's lights, maybe those lights are flickering, maybe there's no lights at all. And so, we're trying to make those neural pathways more strengthened. We're trying to redirect attention away from those really practice persistent pain pathways into these other roads that we're going to bring a paver to, that we're going to set up lights to, that we're going to clean the signs off of. And so that's, another metaphor that I might use. And when you're practicing pain, right, when that pain is persistent, when it's chronic, it leaves your nervous system sensitive. So that in that case, small signals from the body might feel really magnified. So even stubbing your toe might feel like a really significant pain. For you, that might not feel that way for someone else. And your body's warning system becomes highly reactive. So I use a fire alarm metaphor a lot. If you are in school or at work or in a hotel or any building with the fire alarm goes off, it's really uncomfortable, right? There's bright lights, it's super loud, the sound of the alarm is usually really piercing, like your whole body, your face reacts. So you've got the loud blaring of the alarm, you've got the lights flashing, but there's no fire, right? It's not related to an actual fire. There's no structural damage. There's no tissue damage. It's just like a false alarm going off. So someone has a recommendation that their daughter taught them, practice makes better, which helped their millennial perfectionistic self. I totally get that. And we'll talk about perfectionism and how that's a personality trait that could predispose a person to experiencing more discomfort with non-structural tissue damage. So I think that's a great recommendation. And then someone else commenting about how their nervous system was so used to feeling pain after a hip injury that they expected it every time they stepped down. So to go back to the IASP expansion, right? We learn pain. We expect it. We then might avoid it. And that might cause some other issues by just avoiding it. That we become stiff, and there's accommodation and how that impacts the rest of our body. But yeah, being able to recognize that and reevaluate it differently is so helpful. And that's something that we'll do and talk about a little bit more with pain reprocessing therapy for sure. So yeah, some people are really resonating with the pain and perfectionist experience. I totally get that. I'm a perfectionist. I have chronic pain. The things that they say, the theories and the science behind it, it makes sense. So this someone else is also commenting it's a helpful way to validate pain while also offering hope of decreasing suffering. Absolutely. Yeah, as I said earlier, many folks, they have felt their pain being dismissed and they feel stuck. And I think that comes from hopefully well-intentioned medical providers that maybe don't have this experience or maybe just have yet to incorporate it or integrate it into their typical practice. But again, sometimes even the recommendation that a person seek out therapy for physical chronic pain can feel invalidating because they feel like they're saying to them, this pain is not real. There's no structural damage. A medical provider should not be the source of support for you. You need therapy. And this idea that it isn't real, even though it's very real, very valid, just because it's coming from a three-pronged biopsychosocial approach and impact does not mean that the experience that they're having is not so real and so devastating. But I think the stigma of that alone can keep people from seeking out therapeutic interventions for chronic pain. And so connecting it with pain science and bringing in other individuals in their life, that social aspect to support them and to understand and be able to communicate these things in an effective way from both perspectives is really important. So that's why I think the biopsychosocial approach is so great. Loving the interaction. Keep at it in the chat. We'll do a little bit more, then we'll take our first break. So faulty alarm system metaphor, again, a metaphor person. It is logical, right? We want to this person's point, validate the individual who is suffering, that it's logical that their alarm system would go off and produce pain after an accident or medical procedure. Someone in the chat earlier said that they hurt their hip and they sort of got used to that pain. They were anticipating it. They were expecting it. That bracing for pain in some ways is reinforcing the danger, the noxiousness of that stimuli when really it might be more neutral or even safe. So we have to sort of reevaluate pain and pain input like this individual did. So yeah, letting them know, of course, if they have had structural damage, if they've had an accident, if they have had a medical procedure, and they're feeling sort of that increased sensitivity, that increased pain experience, super logical. Once we address the danger, though, it also makes sense that the alarm would be deactivated and return to its normal resting level of activity. But for some, nerves that have communicated danger, they calm down very slowly and they remain electrically charged. They remain really sensitive. With extra sensitive nerves, things like sitting, reaching, bending, it causes the nerves to fire those danger messages to the brain. And one of the authors I really like, it's in the references, Adrienne Lowe. They're a physical therapist. They wrote a book called Why Does It Hurt? And it's just a beautiful example of sort of like a pamphlet, a bound pamphlet that has a lot of pictures, a lot of metaphors, but they talk about nerve neighbors. So I think, again, about fire alarms and having like being in a home, for example, right, where the fire alarm is going off. And at first, the fire alarm might only impact the people in the home, right? The person who's closest to the fire alarm, then the people who are just like in the home but hear the fire alarm. If it increases, it might start setting off water. So that might wake up some people that didn't hear the fire alarm. And eventually, if it continues to go off, that family exits the house, evacuates the home. Maybe the neighbors start noticing that there's lights and there's sounds and there's water and people are leaving and there's commotion outside. So the neighbors are starting to be disturbed a little bit. And then that might expand to like the full neighborhood. And the town is now notified because there's an alarm going off. So the police department, the fire department, EMS, the ambulance, they're all coming. So there's lots of commotion, there's lots of alarm. So it might not be just the point of injury or the original point of pain. You might notice, and this is a good tell for whether or not it's neuroplastic, so we'll cover that later in the assessment period, but it's a version of, okay, it started in my shoulder, now I feel it all the way down my arm, now my nerve from my shoulder to the tip of my pinky hurts on the left too. Like, you think of that as the people in the home, the neighbors, the whole neighborhood, the town, the ambulance, the police department. And so that's a really good way to sort of use a metaphor for like how the one single false alarm, a misinterpretation of a danger stimulus, can activate the whole body, can have your whole body on high alert. Someone asked if I could share the author of the pamphlet again. It's Adrienne Low, Louw. It's in the references. But when we get to the end of the training, I'll highlight it again in the reference section. But they have a bunch of books that they've published of like, why do I worry? Why do I hurt? Things like that. And I think they just do a great job. And for me, because I work with adolescents and young adults, I think it's really applicable across the lifespan. So I try and find things that work for both younger individuals and, adults in general. Let's talk about these two examples of individuals who experienced pain, and then we'll take our first break. Yes, thank you so much for putting that in the chat. LOUWPT, PhD. Okay, so this individual, we're talking about two construction workers. Again, great examples to sort of tie together all of this pain science and the impact of the biopsychosocial approach for a client, just for psychoeducation, but also a little bit for the buy-in of using therapy to manage their pain when they've probably come in having tried everything else. And thinking of how that could be. Someone asked, with this concept of pain, does itching, perceived skin irritation work in the same way? I think there's like a dual aspect of putting like lotions or irritants on lotions or other like creams on a skin irritant that is both the soothing aspect of the cream and what's in it, but also applying the pressure and like rubbing a little bit of the cream on it. So yeah, I do think that there's some of this theory that does play into itching and perceived skin irritation in different ways. I can also understand like itching as a possible way to, obviously if it's a light itching, right? Because I have clients that engage in self-harm. I want to be mindful and do some more assessment about like the type of itching and how hard they're itching, and are there like welts, or are they breaking skin? Are they causing scabs? But if it's just like a light itching, almost like a tickle, like people like to have their back scratched, right? That can be a form of like the larger nerve fibers that touch, that pressure, that sensation that might also help with whatever discomfort you're experiencing. So for example, I get a lot of bug bites. I don't itch on the bug bite, but I'm a person that was sort of taught to itch around the bug bite, or even like use my nail and like create a little box around the bug bite. And that does make the bug bite itch less for me in my experience. But I'm not actually itching the actual bite. I'm itching around the area of the bite, but it's still sort of beating a more uncomfortable sensation for me. So those are maybe some examples that hopefully answer your question. Okay, so terrible pain, absence of bodily harm. We're talking about construction workers. We're back in 1995. British Medical Journal reported that after jumping onto a plank A 7-inch nail pierced a 29-year-old worker's boot, clear through the other side. Jumped on a plank. There was a 7-inch nail sticking up. Stepped on the nail, and he saw the nail like pierce directly through his boot, coming out, the sharp part coming out on the other side. He was immediately rushed to the emergency room. He was given opioids to manage the pain. He was there. However, when doctors removed his boot, they discovered the nail never penetrated his skin and actually just passed between his toes. The receptors, though, in his body reported to the brain that a nail had punctured his boot and his foot. So his brain, perceiving that hand grenade instead of a baseball, right, used context to determine what had occurred and to communicate those sensations. So pain is never purely physical. In order to determine what happened and how to respond, he collected sensory information. So the visual of, stepping on a vein and having a nail and having it like stick through the shoe, pretty scary, pretty dangerous, I would imagine it feels like. Also, just the knowledge of a risky, somewhat dangerous work environment, but also the verbal and nonverbal cues provided by his coworkers who witnessed this occur and started screaming and panicking and calling 911. So those thoughts, beliefs, emotions, they set up a full ripple effect of all of the biological and neurochemical processes. So the sum total of all of this, brain decided he was in danger. And so it was, this experience of pain that he experienced to protect him, to like keep him off of his foot, to not do anything until it was addressed and he was taken care of. Real pain. So to validate those people that feel like, oh, if they're saying it's all in your head, it's not real. No, this is real pain, was generated by factors having nothing to do with actual tissue or structural damage. Then we have little pain in the face of real damage. There was another construction worker, so risky job, right? Using a nail gun when it unexpectedly discharged and hit him in the face. His injuries, he just had a mild toothache and a little bruise under his jaw. 6 days later, because of the mild toothache, he went to the dentist. No other reason. He lived his life for 6 days, and an x-ray revealed that a 4-inch nail had embedded itself in his head. So when the nail gun went off, there was something that was embedded into his head, but because he didn't feel any of the pain in that immediacy, because no one was there to provide context or fear, and all he had was just a little toothache and a bruise for context, he just thought, okay, I'll go to the dentist, I'll just make sure everything's okay, and found a 4-inch nail. But because all of those cues failed to put him on high alert, his nervous system remained pretty quiet, despite actual bodily harm. Let's see here. Someone's asked, what are thoughts on trypophobia and its trigger of a strong discomfort or skin crawling sensation? Yeah, there's no actual bodily harm. It's purely visual. I guess I would do, and I'll make a note up here to sort of bring myself back to this comment when we get to sort of mindfulness and somatic tracking, like turning inward to face the sensations that we're experiencing in sort of a neutral or even safe way. I would want to do some somatic tracking with them. And after I sort of built up their knowledge of some pain science and equip them with coping skills to tolerate distress, then I might do a little bit of exposure and response prevention. Let's see. Okay, it's all in your head. We've already talked about this. The implication is it's not real, right? Pain is located in your head. It is in your brain. We have a central nervous system. It takes information, it communicates it up, and then it communicates it back out. When we have pain, our brain really is actively processing it. How that processing occurs and sort of the development of the theories from the sensors to these 4 grouping modalities to a combination of biopsychosocial impacts, the social cues and context of the construction worker, that all determines how our pain sensations are experienced. And even though tissue damage is maybe not there, that their tissue itself may not be in danger. That pain is real. And so another pain psychologist I really like, Dr. Softness, you'll see it right there on the bottom. And then there's workbooks that are cited in the references that I really like using with clients. She's very CBT based in the therapeutic interventions for chronic pain. She says, just as going to the gym to exercise your body doesn't necessarily mean there's something wrong with your body. Going to therapy to exercise your mind doesn't mean there's something wrong with your brain. So we're not saying there should be shame or embarrassment or other stigma related to going to therapy to address some of the impact of the brain on the experiences of these physical sensations, this discomfort. You're just working it out. You're just learning about it, just like you'd be learning about different muscle groups and different exercises and different circuits if you were to go to a gym and meet with a personal trainer. So I think that's a really great way to communicate. And it seems like there's people in the chat that are already doing things like that. So let's stop there for our first break. We've made it sort of through the bio portion of today's training. So appreciate you guys. Some people feel like that can be a little bit harder digestible information, which is where I think the metaphors can really come in handy as we sort of absorb it, but also as we work to communicate it effectively to our clients. Let's see, someone was saying there's work by many in the physical therapy field to increase the use of the biopsychosocial model of pain. There are actually international groups and summits explaining and promoting it. Yeah, definitely. Unfortunately, insurance and time restraints are often limiting. Yes. I, have the privilege as being a private practitioner of not necessarily having to use insurance and being able to work with some of my clients on a longer term basis. And I do feel like a lot of the things that I, include here, try to include here, are really parts of a general toolkit that a clinician can integrate as part of their work to use as even a singular skill. Like we've already talked about somatic tracking, I've mentioned it. We're going to go into it in a little bit more detail when we get to pain reprocessing therapy, but even taking some individual techniques and tools from this type of work can be integrated into a short-term therapy regimen with success, with reported success from clients, with reported success from research studies. And so, yeah, I think coming to a training like this, hopefully as someone maybe who works within the pain community, but who might not be someone who works directly with individuals with chronic pain, but like me earlier on in my career, was seeing a lot of somatic manifestations of these emotional experiences, trauma, anxiety, depression, learning some of the ways to experience how the body might communicate that to the brain, and then back through the body, and what we might do to both intervene on a cognitive level, on a behavioral level, but also communicate what we need and how we can be supported from those around us, are things that I think could be really beneficial to most presenting concerns. So I really do believe in a lot of these techniques as just even singular coping skills to add to your toolkit. It doesn't have to, like CBT for pain or PRT for pain is not just sort of like a one modality fits all and covers all. It's sort of thought of as something to integrate. So when we think of sort of the cognitive behavioral triangle and the cognitive behavioral cycle, it's, multi-directional. Everything is impacting everything. That's kind of the whole point of the biopsychosocial model. So we're starting with what we think. Things like I'm broken, I'll never get better, nothing will help, I can't handle work. That's where the research shows those impacts and reductions to ADLs and work limitations. That then impacts and vice versa how we feel. Emotions like being afraid, being stressed, feeling really angry and frustrated, feeling a sense of betrayal even from the body, being really sad. And then the body responds with symptoms like headaches, stomach aches, fatigue, panic symptoms, and that does impact our behaviors. Like some people have already mentioned in the chat with personal anecdotes, like their anticipation of things sort of had them refraining from engaging in certain actions and activities. I know for me, that was certainly my experience. And for a lot of my clients, that's their experience. So avoiding activities, not just for working out, but moving in general. Staying in bed, isolating from social situations. So this is, a graphic if you have some more visual learners in your caseload that you might be able to use. This might be the first time that someone is asking a client to reflect on this mind body connection, right? On the somatic manifestations of their thoughts and feelings. They might not have this realization yet or have this background knowledge that physical symptoms can be connected to emotions. So, especially with my younger individuals, or my nonverbal individuals, people were just like, language is not, verbal communication is not their chosen mode of expression. I use body drawing templates a lot, but this is not just applicable for younger clients. All ages really respond to this. So I'll show you an example, but I have these worksheets that look, like this, and I'll come back to it in a second. But I pull out two, one for me and one for the client, so they don't feel weird or embarrassed completing one while I'm just kind of like sitting there and watching. They're probably worried about what I'm thinking if I'm judging them. I also have crayons, colored pencils, markers. You want to be sort of prepared for all visual and sensory preferences. And then we use that to communicate their experiences. So for this person, when they were experiencing anxiety, they were having a lot of somatic experiences, including feeling like their head was really cloudy, their ears got really hot. So you can use words. Just because it's a nonverbal activity doesn't mean you can't use words. They use the word hot. They could have, in theory, like drawn flames. It's really whatever they want. I'm sort of giving them some examples, but I'm not guiding them through it. I'm sort of allowing them the time to fill it in themselves. They've felt like they have strikes or flashes of light, or pain behind their eyes. They feel like they're butterflies and their stomachs are all twisted, and they maybe have, clammy hands and feet. So I see that some people are using these body drawings as well, and feeling like it's an excellent tool. So I'm glad to see that this is already in action. I highly recommend, and I find it to be very helpful. Oh, this is really interesting. They like to use the body drawing before and after somatic practice that the client can see the movement. Yeah, I usually have them, like, the point of somatic tracking is to use language to describe the sensations, how they move, what it feels like, what it looks like. So we do use a lot of imagery. And even in my sort of positive affect induction and tracking, I will prompt them using imagery. You'll get a script of that as a handout as part of today's training, so that you can read it. But I really like the idea of using the body drawings pre and post to see how their sensations are moving. And, just to put a bullet point on it, the idea and the fact that their pain is moving and changing experiences does, again, provide evidence that it's neuroplastic, because typically structural tissue damage doesn't move. It's like localized to the area of where the structural tissue damage is. And so that's where, again, you're kind of collecting evidence, because maybe they'll have some a hard time sort of buying into this idea that it's sort of generating from the brain. But that's a really great idea. Language matters. You'll often hear clients say that they feel weak, that their body is weak, that they're damaged, that they're powerless. And I think it's really important to highlight the importance of language, like the ears hear what the mouth says, the body feels what the ears hear. There's a lot of connection with all of that. So trying to change their language to being strong, being capable, being powerful, and having them, catch those things in the moment while you're there modeling that for them so that they're sort of now starting to attend more to that language. So hopefully in between sessions, they'll start to be more actively aware of the language that they're using and catch it and modify it. Sometimes in the earlier phases of that more cognitive restructuring or cognitive reframing of the work, I might have like written or visual reminders of the language that they should be using more often or trying to reframe to, whether that's things that are literally written on like bright pieces of paper that they have where they're going to see it, like their bathroom mirror or their kitchen table or their dashboard or even on their phone as their background. Or a lot of my clients will use the adjustable text on their alarms that they go off every morning that they're looking at probably more than once because if like me, they're snoozers. And so they're seeing the text of the language that they're trying to look for and replace and utilize instead. So any verbal, visual reminder that they can have, the more likely they're going to be able to internalize that and catch that information and flip it to be more effective, more positive. See that's something that other people are using, good reframes for more positive descriptors. And you can have them reflect on it in sort of a sense of journaling if you want, if they're open to it. Not all clients are. And I kind of give them different options for how they might journal. They can write it out, they can voice memo themselves. Not all of my clients want to be writing more after school, after work. But they hear the benefit of sort of getting that stuff literally off your chest. And so having it somewhere on a voice memo, on a piece of paper, typed out, they can keep it, they can send it to me, they can shred it, they can burn it, whatever they want. And they can also share it with the people that are in their lives. Like that's a good way to kind of communicate to them if they're comfortable. And we'll talk about boundaries later, that they can use as sort of a jump off point for conversations. But you can have them describe a time when they were distracted, happy, relaxed, having fun, and their pain felt a little less bad, right? That's sort of connecting the mind-body connection, the impact of psychological factors on their physical experience of pain. Ask them what lifts their mood. Differentiate what relaxes the body and relaxes the mind. I often use nighttime as a metaphor or an anecdote for this. A lot of clients will have like they're ready for bed. Their mind is, super quiet. They're exhausted. They're not thinking about anything, but they're feeling really fidgety. They're feeling really restless. They're like tossing and turning and can't really fall asleep. So what relaxes their body versus relaxing their mind? Maybe their body is exhausted. They feel heavy. They feel lethargic. They just want to fall asleep, but their mind is running and running and running. And so differentiating those two things, but also having them build insight into both. Someone said strategically placing photographs of times they felt strong and capable help. Love that. That's a great visual prompt. What emotions trigger your pain? What situations trigger your pain? What do I predict might happen because of this pain episode? When pain shows up, what do I tend to stop doing? Like, where is my avoidance? How does this impact my actions, my behavior? What's one small values aligned action I could even try while I'm uncomfortable? What's one alternative explanation for the pain besides something is wrong? Like I am hurt, because hurt doesn't necessarily equal harm. And what evidence do I have that my body has handled these sensations safely before? So that pairs perfectly with the last chat comment of sort of strategically like having to journal about this, but also placing photographs of those specific times if they have images of it to sort of, again, we're working with all different types of learners. Clients are coming in and they might be different like receiving knowledge and letting it absorb more different times of day. So having visual and verbal feedback and auditory feedback sort of punctuating all of these points is going to be the best way. Someone said, imagine the insight helps neural pathways form or strengthen. And I wonder if this also helps close the gate. Absolutely. I think that the early message about the insight does certainly help the pathways, the neural pathways straighten, because we have research that shows that having pain neuroscience alone impacts a person's experience with pain. We just also have the knowledge that plus some of these interventions and the social support further benefits their experience of pain. And while I think when we think psychologically about the gate, that it certainly does help the gate control theory is mostly related to and like based about the foundations of these nerve fibers, so very biological. But the whole point of this is that the biological aspects of our experience are also impacted by our psychological and social aspects. So I certainly think that even though they might not have written about it or still writing about gate control theory with that in mind, it certainly does impact it. Someone said, do you modify for neurodivergent clients? Sure. It depends on, that's sort of why I have all of these different options listed, and every client is different. So figuring out for them if they're writers, like pen to paper writers, are they typers, are they people who don't want to write at all and just like want to talk about this stuff when like whether they're able to concretely like carve out time to do it, or they're just talking about it out loud while they're already stuck in the car and they can't go anywhere and they're choosing to voice memo some of these thoughts while they're just sitting in traffic, working certainly with each client and their preferences, to try and build insight into these things, definitely. Also, for individuals that don't like to write, but like text as a way to communicate or express, they can use blackout poetry. This is also a good way to write about feelings that they're having, or maybe moving toward feelings that they would want to have, like if they're wanting to redirect their attention to more positive experiences, then they can use blackout poetry because they're connecting to someone else's experience, and that for many people is easier to start when you're working on sort of expressing your feelings or connecting to those feelings and tolerating that discomfort, to connect to someone else's experience that resembles yours or serves as sort of an ideal for you before they start saying, I have been doing this. So you take any existing text. This is a book that I didn't care to be marked up. I have magazines, newspapers, lots of things in my office for people who want to like use art or nonverbal expression, for collages and stuff like that. But they're taking a black magic marker, it could be any color, and they're blacking out the words they do not want to use. They can also black out parts of words if they want to save letters. This could like they could black out everything but a single word. They could black out everything but a few letters to make a word. It's whatever they want it to be. There really are no rules. This person took something unrelated to like a mental health message and left. I had been treading water, exploring the depths, following all the way down. It was a cold and lonely place. Then it occurred to me, such power. The sun sends a dazzling band of light across the sea, a shining sword in the water. So both leaning into more somber experiences and then ending on a hopeful note. And it can be one or the other. It could be both. It could be neither. And what's really amazing about Blackout Poetry is there's a community of Blackout poets. So there's forums and Blackout Poetry jams. And so if they find themselves really connecting to this or really enjoying the activity, they can connect with other individuals that also share their passion for this type of sharing. And they can, see them online, they can connect to them online. It's just like a great way to have community, while also leading to it into expression in maybe less typical way. You know, we hear about journaling, lots of people journal. I recommend journaling a lot, but for a lot of my clients, they're just not into writing. And so this is a great way to have them process their emotions. And I'm going to go back to the chat because I see someone asking about fibromyalgia. We might wait until the end for that. I might be jumping ahead, but wondering if you can speak on fibromyalgia. Many people say that it's something that is diagnosed when nothing else can be found. How is this disease working with the brain as it relates to pain? Yeah. A lot of the pain psychologists that I follow and have learned from would sort of describe fibromyalgia as neuroplastic because there's not necessarily structural damage, but it is a very real, very can be debilitating. There's a spectrum of fibromyalgia, right? Experience of pain. So yeah, it's like a diagnosis of exclusion. If you can't find anything else, they might say, oh, I think it might be fibromyalgia. And so a lot of individuals who use PRT would highly recommend pain reprocessing therapy to treat fibromyalgia. And we can talk about it more later as we have time. Someone asked, just curious if you have certain pages you like to give clients for blackout poetry. No, I think the whole point is to allow them to find what they want in the page that they have. And I do it with them sometimes. And there's certainly instances where I look at a page and I'm like, there's nothing here for me. And then they just use another page. I have lots of books that have been read that can be borrowed and sort of destroyed or created new art from the existing art. And so they can kind of peruse pages if they look at a page and nothing jumps out at them. So I think that that can be, yeah, you can, if there is something that you are maybe wanting to prompt in them, like hoping they recognize a certain word, or you see a page that has multiple words and you're wondering if, like on this page, do they leave the word treading? Do they leave the word depths? Do they leave cold and lonely place? Or do they leave such power? The sun, a dazzling band of light, a shining sword in the water, right? So there's just so many opportunities for expression and for insight building, both from the client, but from the therapist as well with blackout poetry. So that would certainly be sort of like a projective assessment measure in a way, if you wanted to select pages and see what they choose. But I sort of leave it free will to them. They can flip through pages if they don't see something that they like. I also love to tap into the five senses. I make coping kits with my clients. So I ask them what they typically do to feel better when they're not feeling great. And this really can also tap into the communication that they might have with their support network. But I'm asking if they're, watching movies, reading, are they on social media? Are they taking pictures? Are they someone really responsive to light? Some really cool opportunities if they're sight-minded for self-soothing are to log into sort of like live nature cams. So a lot of aquariums and zoos and just like animal like rehab centers have like 24-hour cameras on tanks and on enclosures and on just like parts of the ocean where you can just watch animals live, and that can be really beneficial for people that are sight-minded. Sound, people might lean into playlists. I have clients that have panic playlists, both to lean into that experience, but also to sort of redirect their attention to something more positive. Maybe audiobooks really soothe them, having sound machines before bed. There's guided meditations. There's lots of apps for that. Maybe their touch, individual soft materials, having a robe or a pair of socks or a headband or like an eye mask that they love when they're not feeling good, that will help them sort of feel more comfortable, but maybe also just ease pain. Squishy things, if they respond to temperature, they could take a hot soak. They could use ice packs if they're really responsive to pet love. And then smell and taste, scented candles, a favorite soap. I always have chocolate, things that are spicy, as in like cinnamon spicy or sour, like warheads, and nostalgic flavors to sort of have in their toolkit. Someone asked, is the point of blackout poetry to leave positive words or affirmations only when they're done reading it? No, not necessarily. That can be one of the benefits of blackout poetry. Like if they are wanting to lean into more neutral or safe or positive experiences, but it could also just be an opportunity without quite connecting to their own experiences to like feel a connection to some of the harder feelings like depression or anxiety or anger that they might feel more hesitant or limited to express on their own before they're sort of saying like, I am angry at this about this. They might be able to connect to someone who is angry on a page and leave that as just like the way to sort of like acknowledge that that's something they connect to tolerate that discomfort. And perhaps if I were to see someone only leaning into that use for blackout poetry, I might prompt them to or encourage them to try and find something more neutral or more positive just as an exercise. But really, the blackout poetry is to be used by them to connect to certain experiences and express what they want in whatever way they find to be helpful. So yeah, there can be some prompting through the navigation of it. What's really amazing is it really could serve any purpose. So that is a good idea. Someone said, I recently did a training on binaural audio for pain. Have you used this or heard that it has been helpful for people experiencing pain? Yeah, I recommend Insight Timer for some of my clients and who are more like auditorily, they have an auditory preference and they can do things like binaural beats for sleep, for relaxation, for calming, and that impacts a person's experience of pain. And sort of the virtual reality aspect of some of the apps that I work with and use really utilize audio input as a soothing format, a soothing modality. So I definitely would recommend bringing it to the attention of a client, certainly prompting them through some binaural beats or binaural sounds in your session. That could be sort of like pre or post a tracking, sort of like the individual is using a body drawing. But I think it's certainly something that's worth utilizing. And there's a lot of science behind using sort of like those binaural beats to truly impact the like placement of our brain waves all the way from like really activated to in like full sleep. So I think that relaxation can also really apply to individuals that are experiencing pain. So yeah, some people have used Insight Timer. Someone's asking if it's an app. It is an app. It used to be completely free. Now I think that there's some things that are free with some like subscription options if you wanted to do that. People talking about music is magic. I really love that. So yeah, this is an image of some of the coping kits that I might make. These are just like all of the items. It's not necessarily all of this in one kit. I'm just taking like one thing from each of them based on what my client is responding to and giving them like a little baggie or a bucket or a basket to bring home. And so you'll see on the left, I have sort of like those masks for clients that have headaches or respond well to temperature because you can put them in the fridge or the freezer. I would caution against putting them in the microwave. There's been, a lot of things that I've seen on social media with people microwaving like stress balls and it's not intended to be microwaved, then the likelihood that it might open up or explode and that the stuff inside is really hot is just it's dangerous. So I'm always recommending to keep it cold. But I have like weighted face masks. I have shower steamers, kind of like bath bombs, but rarely do my clients have bathtubs. So having shower steamers that they can put on the bottom of their shower, like where the drain is or where the water hits. And then it sort of gives this, taps into the smell, sense, and is the sort of aromatherapy, having journals, mints, candles, fireballs, warheads. The ice cubes that you see on the bottom, they're reusable. So they're meant to be put in the refrigerator or freezer. I like to keep them in the fridge because I really like that there's water in them and you can like hear and see the water moving if it's cold. But a lot of people might recommend holding an ice cube, right, as like a mindful exercise, as a way to redirect your attention to something somatic. But ice cubes can sting and they melt. And so not everybody really likes that sensation if they have sensory issues or if they're just not feeling like being wet. So that you can use these reusable ice cubes and carry them around with you and hold them. A lot of these things are sort of like held within your hands. And it won't melt. And what's great is because these ones in particular are colored, that taps into the visual aspect, and they're translucent. So you can use like a magic marker or something to put a reminder of some powerful words, some people in your life that you love, a reminder for certain coping techniques that you might not be thinking about right away if you're feeling really overwhelmed. But when you reach for these skills, that's kind of the idea. If you're overwhelmed cognitively, you're not necessarily going to tap into your brain toolkit and say, okay, I have all of these skills that I've learned from Dr. Jamie, and I'm going to use this one and I'm going to try and implement it and see if it's effective. None of that's happening. The person is just overwhelmed. If they're in a flare, they could feel down for the count. So to have items like this in a basket where they're anticipating being in a flare, or they usually go like their bed or their couch or just like an area of the home, in the car, at their desk, in their locker, in their purse, that they can just reach for without thinking about it. And they know that that thing that they have is soothing. Once they bring themselves into a more soothing, stabilized place, then they might have more access to those cognitive skills. So writing a prompt on the reusable ice cube for those cognitive skills might be a good way to sort of purchase them. Someone that has a similar idea, purchasing some reusable hand warmers, just boiling them to reset them, but they're great. So yeah, there's so many different versions of, temperature, which I do find a lot of people, especially in pain, respond to temperature. They tend to have a preference. I am a heat person, but I know people who respond really well to cold as well. Lots of people are talking about wanting to add their pets to their coping kits. I totally get that. That's where Furry Friends is sort of on the sort of touch aspect of self-soothing, but this is really great stuff. Clients of every age are excited about this, utilize it. If they're having a particularly hard day, they now know that I have these tubs of things that are like hidden in a closet, and they might come in and be like, can I look at the tub? Like, can I please say something from the tub? And once we figure out from this coping kit which senses are their dominant preferred soothing methods, then we can generalize our tools and techniques that we're trying to match what feels best for them, what they're more likely to access, what they're most likely to implement effectively. And most of the things that I get for my kits are from the dollar store. So I try and make it pretty affordable. They can then build their own coping kits. And it's just a fun thing. They're not going to like walk into a social situation and have someone be like, oh, did you get that at therapy? Like, this is just something that they could purchase for fun, and it's not necessarily identifying them as patients. So lots of people have lots of good ideas for soothing things. If a client is feeling overwhelmed physically or emotionally and can't get out of bed, I will sort of walk them through these prompts with me in my office at first. I'll sort of have them think about getting out of bed. visualizing themselves successfully standing up, walking around the room. Depending on the age, what they're coming in for, I might do some relaxation techniques, maybe progressive muscle relaxation, maybe some body scanning, which is a different version of somatic tracking, but also have them use some self-talk, right? We're sort of in CBT land. I've gotten out of bed a million times before. I can do this. To the chat point earlier, having pictures of them like doing activities that they used to love, like having those be visual reminders, communicating that moving will not harm my body, even if it hurts. That doesn't mean that there's harm. Then have them wiggle their toes once they're in bed or on the couch with you, get the blood flowing. Again, some progressive muscle relaxation, tensing and releasing your body when we're thinking about bedtime or getting out of bed. More focus should be on the calves, on the thigh muscles. Have a reward. Think with them in session about what some of these rewards might be. It could be eating, it could be making a breakfast for yourself, it could be having someone who's at home make a breakfast for you. It could be getting to a place where you can purchase a little coffee or tasty treat. Maybe you're going to be watching a show, cuddling a pet. That taps into a lot of the things that people were talking about earlier, like wanting to add their pets to the coping kits. Then, have them know that they've tensed and released those muscles, move their legs to hang over the side of the bed and really ground them, literally have their feet touch the ground. More self-talk, one step at a time. I can do this. I wiggled my toes when I felt like I couldn't move at all. I was worried it would hurt. It doesn't hurt. Even if I'm a little sore, I know that movement is, not the monster. And have them stand up slowly, walk toward their reward and really emphasize and reinforce for them the importance of pride for their efforts. We'll talk about spoons and spoon theory later in the social aspect of this training, but a lot of them might, dismiss their efforts, whether or not they've been invalidated by other people, which again, intention or not has likely happened. They'll often invalidate themselves and say, okay, I should be able to get out of bed. Like this, I feel so awful that this feels so debilitating that I can't even get out of bed, that I don't want to get out of bed. But the fact that they visualized it, that they wiggled parts of their body, that they moved a little bit, even if they're getting out of bed to in the same pajamas, move to a comfortable couch in the room next door. We're not asking them to get out of bed, change, and go walk for 3.1 miles. We're just asking to move out of the space that you're in, and see if that helps in any way. And if movement actually does get the blood running and makes you feel a little bit better, maybe you can lean into some coping skills. But also being mindful, if you're in a flare, what your body needs, and having, again, those people that are in your social network knowing that too, so they can support you. But often having to monitor and model the reinforcement and the praise for effort first before they can sort of internalize it. And often they internalize our voices first. Clients, walking around saying they have a little Jamie cheerleader in their head, prompting them through these things. Some of my clients have even voice recorded me walking them through some of these things, or me saying the words that they want to redirect their attention to, or if we have mantras or self-talk or things that they just connect to therapy that feels really helpful, then they'll record me. But eventually I want that voice to be theirs. But it is pretty cool that our clients are walking around with little versions of us in their heads. Okay, pain reprocessing therapy. So PRT does provide patients with a causal model of pain. It's talking about the fact that it's due to processes in the brain and the central nervous system that occur in the absence of structural damage, so neuroplastic pain. It markets pain as a false alarm and emphasizes that pain is reversible. I cross out pain because sometimes that word itself can be associated with negativity and discomfort. So I might instead use words like discomfort or uncomfortable sensations. I use sensations a lot, or physical experiences instead of the word pain, because again, pain has sort of like this learned response of being negative, being hurtful, being harmful. PRT promotes the expectation that neuroplastic pain can be substantially reduced or eliminated with psychological treatment. They do promote that expectation. I don't tend to use the word elimination as a practitioner. I find that that could set a client up for like early failure in their mind if they can't like fully eliminate the pain, which is very unlikely immediately. Like this does take a little bit of time. And so I don't want them to feel guilty or shameful or embarrassed or resistant to future treatment because they're still experiencing pain. The idea is that, you know, pain is a protective measure from the brain and that sometimes we're going to experience it. And even if we understand and learn to tolerate and then manage those sensations that bring a client into your office for the first time, the likelihood that that goes away forever is really small. So we're really not preparing to eliminate pain. Like that's not the evidence of completed successful treatment. The evidence of the marker of sort of like progress and success is that they are open and ready to feel that sensation again, but they have the ability to view it through a lens of neutrality, through a lens of safety. They can identify that it's a false alarm, even though it still might be really scary and anxiety provoking or make them feel sad or frustrated that that experience, that sensation is something that they're having in that moment. They know what it is, they know what it's not, and they know how to manage it. So someone asked, is PRT only for when there's no identified structural damage? It's designed for that. That's like foundationally how it was created, what it was created for. But example, like chronic pain for rheumatoid arthritis, absolutely. I think that there are many, like I have some neuroplastic pain and some structural pain. And it is effective in managing both. So I find it to be helpful as a tool for things that even if it's not related to structural damage, or there is structural damage, like very real imaging, and we'll talk about, you know, the weight of imaging and how that might impact a client. But yeah, I think even with imaging and healed injuries and things like that, it's still really helpful. Let's go back. Yeah, I sort of already talked about this, but studies have found that pain neuroscience education alone does have effects, but limiting effects on reducing or preventing chronic pain because the combination of both that neuroscience and the psychological intervention and the social support that's been found to be most effective. There's a lot of therapeutic influences on PRT, cognitive behavioral therapy, as we just reviewed, and that in a lot of ways, PRT pulls the decrease in pain catastrophizing. Then there's exposure-based therapy, emphasizing that painful activities are not injurious. There's a lot of reasons, the anticipation, the association and reinforcement of fearful or dangerous movement, even some discomfort, like physical discomfort and hurt, that those things aren't actually causing injury or more injury. So there's some exposure in that behavioral activation aspect. Acceptance and commitment therapy. So enhancing pain acceptance as saying, okay, this is just the sensation I'm experiencing in this moment. It's likely related to these things. And this hurt doesn't necessarily mean I'm in harm or danger. And then mindfulness-based interventions. So promoting non-reactive attention to bodily sensations. When I think of like the full structure or like an agenda of PRT treatment, it's broken down into education about brain origins, reversibility of pain. So sort of taking those earlier paved roads, those neural pathways, and redirecting attention to new practiced pathways. that are sort of cleaned up and well lit and well signed and paved through the use of therapeutic intervention and support. And studies have shown that your nerves will immediately start calming down when your awareness regarding that pain neuroscience and the root of your pain increases. So that I think taps into one of the other comments that was mentioned in the chat, just about just like nerve impact and gait control theory with just like that neuroscience education itself. Then there's gathering and reinforcing personalized evidence client to client for the brain origins of pain. Then attending to, this is where mindfulness comes in, and appraising pain sensations through a lens of safety. Gravitating toward positive feelings and sensations. So someone had asked if the point of Black Hat poetry at the end was to really emphasize that positivity. So in PRT, we're sort of leaning into that discomfort, those physical sensations that might be uncomfortable, and learning how to view them more openly, more curiously, without judgment, which sort of removes that reinforcement of danger or threat. But then we do redirect them to those positive feelings, which they just refer to as positive affect induction and sensations. And then assessing other emotional threats. PRT is, considering the impact of other moods and emotions and dysregulation on the experience of physical pain. So also addressing whatever anxiety or depression or frustration tolerance is needed as part of the treatment. Someone said, with the therapeutic approaches, are there any studies where EMDR can be utilized? I am not super well versed in EMDR. I don't have any training or experience with it. I know that EMDR is a great modality for trauma management. And if a client is coming in with trauma associated to an injury or to the experience of having chronic pain, then that is going to be addressing those other emotional threats, that social aspect that will likely lead to an impact on pain management. So I don't know specifically if there are EMDR studies. There's no studies as of right now that combine or compare PRT against or with EMDR, but logically, from what I know about both, it makes a lot of sense that it would be a good tool to use to sort of manage some of the other emotional threats that are impacting a person's experience of pain. In terms of handouts or visuals, the CBT sort of triangle or diamond that I have, I might use as an image, and that'll be in the slide copies that you receive. And then I have a separate handout of sort of some of the scripts of what we're going to talk about next that you'll be able to use on hand in session with clients, and also send them home with for things like somatic tracking and mindfulness. Yes, someone was saying EMDR is utilized for trauma, but it's opened up to so much more. So I wasn't sure. Yeah, absolutely. I think as an integrative therapist myself, I think that it's, so beneficial to have at least some knowledge of most of these things, to know as you meet every unique client, what they might benefit from, even if that then leads to some collaboration with other clinicians, or maybe sending them for some EMDR treatment before coming back to me, if we're not doing it collaboratively. So why evidence collection can be challenging with clients when we're doing PRT and sort of like getting buy-in for PRT. We as humans are evolutionarily wired to associate physical pain with physical injury. It is learned. Many chronic back pain patients have been given structural diagnoses. So it's really hard when a client comes in with scans saying, like, look at this disc bulge, look at this herniation, my discs are degenerating. Like, that is why I'm experiencing this pain. I'm not going to get any benefit from therapeutic intervention because I need to tackle this issue, this structural difference. But in a lot of PRT studies and studies in general, there's been comparison of thousands of people with very similar diagnoses or exact. I mean, it can't be exact, but like this is a disc bulge in the L5S1 area of the spine. And of the thousands of people, 1,000 of those individuals experienced no pain, and another 1,000 individuals experienced their own experiences of pain. So it's not like if you broke your ankle, you would feel like see swelling in that area, see bruising in that area, have a hard time putting weight on that foot. But it would be unlikely that that pain would then radiate like across the leg that the bone was broken in, that would then go to the other side and then would move to different parts of the body depending on what was going on. And so, challenging that evidence, but it's something to be expected as a pushback when you're working with clients with chronic pain. And yeah, has already been discussed throughout the chat and with the PowerPoint, many CBP patients have developed learned associations, like sitting or standing equal hurt. Activities like walking too much, running, even bending over have become associated with this onset of pain, reinforcing the belief that there is something structurally wrong with them. So this is a assessment for neuroplastic pain. So you can take this if someone was asking for sort of like printouts or handouts. This would definitely be something worth printing out that you could have with you during the intake. You can even, I have like assessments that I might send. I might send this in sort of free response or like yes, no, if yes, please explain questionnaire when I'm working with chronic pain patients. But asking, did the pain originate during a time of stress? Is it also triggered by stress? Like, what's the psychological impact? Did the pain originate without a preceding injury? Or maybe they can say, oh yeah, I went for a run, like I ran a marathon. And then 3 weeks later, my ankle started hurting. So obviously I injured my foot in the marathon. But typically, and again, not one size fits all, but that might be an indication that it's neuroplastic, because a lot of times if they had injured their ankle in the run, then it wouldn't have been 3 weeks later. Like they would have had signs and symptoms of the injury at the time of the run. And again, it could start with tissue damage. Like there could be a real injury, a real accident, a real medical procedure, but the persistence of that pain after the injury healed suggests that now those symptoms are neuroplastic. Maybe there's a complete lack of physical diagnosis. Maybe there's some inconsistency. Structural damage doesn't typically vary in trigger and degree. So if it sometimes hurts when you go for a run and it sometimes doesn't, let's think about that. Are there a large number of symptoms? And having multiple unrelated physical conditions is less likely, even though there can be some comorbidity. Do your symptoms spread or move? Are they symmetrical? We've sort of talked about this throughout today, just like paying attention to their description and asking questions, sort of prompting them through these different questions to determine if their pain is in fact neuroplastic. But even if it's not, I still would recommend some PRT techniques. We're also getting a mental health history, talking about ACEs, right? Childhood adversity. People who have experienced trauma in their childhoods are more likely to develop chronic pain as adults. Is there a significant family history of mental health, of substance use? Really anything that made an individual feel unsafe growing up can predispose you to chronic pain, because it's sort of priming your false alarm to go off with less. It's making it more sensitive. That could be cyberbullying. That doesn't have to be something that's considered to be negative. It could just be a lot of pressure, which can feel threatening in some ways to the nervous system. So like an ultra competitive high school or being a really competitive athlete. Those things, while they might not be considered adversity, are sort of priming the brain to be on high alert for certain things and like put a lot of pressure on the nervous system. So yeah, it can cause you when you're having these experiences as a younger individual to see the world through a lens of danger. which just makes you more susceptible to neuroplastic pain. Someone's relating it to the experience with menopause and perimenopause, the pains that move from one body system to the other. Yeah, definitely. And I know that's like such a growing field right now. We mentioned perfectionistic individuals. Perfectionism is common personality traits. You're also checking in on self-criticism, people-pleasing, anxiousness in general. And it's not surprising, again, that these traits are related with neuropathic pain because each one of them sort of puts the brain on high alert in their own way. So when we think about somatic tracking, which is turning your attention inward to the discomforting physical sensation, right? That pain sensation. You're first identifying that feared stimulus. Where is it that your attention is being brought to? You're providing that psychoeducation about the mind-body connection. You're talking about pain neuroscience. You're linking the psychological impacts to the physical sensations, the emotional, like the physical manifestations of those emotional experiences. And the goal is to help your mind feel more safe, more open, more curious. And so you're using mindfulness, you're using safety reappraisal, which is just sort of like positive self-talk, positive reframing, and positive affect induction, like I mentioned earlier, like leaning toward more positive experiences, more positive images, more positive sensations. And if you can't get to positive, which can be a lot of pressure, right? We're really looking for neutral. We're looking for that at least, and then we can make it up to like a positive experience. Someone said earlier, what did they say? Not practice is perfect. I'm sure they'll remind me in the chat. But so as not to, yeah, practice is better. So sometimes I'll say to an individual, like, hopefully you have a neutral to positive day, right? Because we're not going for any like pressure, right? We're setting them up for failure. We're getting them to just move in a positive direction, away from danger, away from fear. And so starting with mindfulness is a great place to begin. Let me see. Let's do the mindfulness and then we can take our next brief break. If a client is ready to have them, familiarize themselves just with their internal state, just bringing attention to a physical sensation in the body, then you could start with mindfulness. I wouldn't start with somatic tracking, which is directly connected to the area that is experiencing the discomfort, but have them start to get comfortable asking themselves these questions. What's the quality of a sensation? And you can prompt them through this verbally. Can you describe the location of the sensation? Is it widespread? The suggestion earlier in the chat, they could have a body drawing in front of them. It really can be as simple as like walking outside and attending to what the sun feels like on their cheek, or holding a reusable ice cube, or running their hands under cold water, reminding them they don't need to change anything. They don't need to do anything or move the sensation in any way. They're just noticing it. It's just giving them practice of redirecting their attention inward toward their body, which they might have a hard time relating to because of this persistent pain. But they're just exploring it curiously. There's no fear, there's no judgment. Prompt them to reflect what happens as you pay attention to it. Does it intensify? Does it subside? Is it moving? The more you're able to watch the sensation from that perspective as a client, the more you're training your brain to go there in the future through that lens of safety. There's lots of different childhood mindfulness activities that we use with my younger kiddos. So coin tossing, like finding a collection of nickels and like a jar and putting them out so that everybody has 60 seconds to like really carefully monitor their coin, what it looks like, the color, the year, the tarnish, the dents, and then putting all the coins together, mixing them up, and seeing who can find their coin the fastest. Paying attention to sounds that are inside the room versus like outside of the office or outside of the building. with ABC games and never ending stories. You can do it internally, but it's best in a group, sort of alternating person by person in order by letter of the alphabet, like a category. So if it's animals, someone saying aardvark, bear, cat, dog, elephant. It ends up being really silly. People laugh. It's sort of that positive affect induction. The never ending story is the same idea, but you're starting with either a word or a full sentence telling a story. And then the story sort of unwinds um, based on where every person takes it. And they've not talked about what the story looks like first. So it never is what it intended to be. And typically chaos ensues. And again, lots of laughter, lots of positive affect induction. People were talking about mindful eating earlier, like really spending time with something like a Hershey Kiss and looking at the wrapping and the shape and are there dents? Is the point broken? Is there any marks on the bottom? What does it smell like? How does it melt on your tongue? What's the chocolate experience when you chew? And for younger clients, scribble art can be really positive and like family building in that everyone on a blank piece of paper has their own um, art, like crayon, colored pencil, or marker utensil, and they each alternate in order of like making a line and creating a picture together that they can kind of take home with them. And then again, never is what anybody wanted it to be, but ends up being this really beautiful thing that they're making together that they can hang up as a reminder of like supporting individuals and not just having this like identified patient. And then yeah, just these are ways to promote mindfulness for individuals that are not ready to tune inward to the body, even if it's not connected to the body itself. So that can be a really helpful way to start. So we'll do these safety appraisal quotes, and then we'll take our 5-minute break. But want to make sure to validate as you're going through all these exercises. They might be having this negative language coming up. We want to push against that. We want to work on reframing, cognitive restructuring. So letting them know, I know it feels like something's going on in the body. Like I know that this feels like structural damage or an injury, but your muscles are healthy, your tendons are strong, your ligaments and nerves are all perfectly intact. This is just a brain overreaction to a perfectly neutral, safe sensation. This is a baseball, not a hand grenade. See if you can pay attention to the sensation. You don't need to get rid of it. In fact, there's nothing even to get rid of. It's simply your brain making a misinterpretation. And then leaning into humor, like relaxing imaging, like the snorkeling script that I gave you the handout for, the Smurfs example. When I was doing my PRT training, we were all like guiding each other through somatic tracking and mindfulness. And my like partner in practice was a chiropractor, and he asked me to turn inward to like a pulsing, like a pain sensation in my hip. And so that's where that's what I brought up. He asked what it looked like. He asked me to describe the sensation. I told him that it was sort of like pulsing. And then he asked me to assign it a color, which I really loved. And I use color as a mode of expression with a lot of clients. If they don't want to use words, they can use colors, and we have like a code of what emotion that means, or like if it's a good day. And so I said blue because my favorite color is blue, as you can see. And he said, okay, well, that makes me think of like a dancing Smurf. And which made me laugh because I certainly had never associated like a pulsing pain in my hip as being like a cute little dancing Smurf. And now that sort of has the attachment. Like if I were to experience a pulsing sensation in my body, I'm also often thinking about like a dancing Smurf. And then I am less inclined to lean into the fear of that potentially dangerous stimulus and think more about this like neutral, now positive experience. You want to remind clients that you're just paying attention to it very openly, very curiously. it's not with intensity, no scrutiny, not like we're studying for a test, because that is reinforcing the idea that there's potentially a threat or danger. We're just paying attention to it with this real sense of effortlessness and ease. Um, so just remind clients of that and be aware of that and utilize imagery as something that they can kind of carry with them without having necessarily a coping kit in their hands. We know that stressful events initiate a stress response, increased adrenaline, muscle contractions, increased heart rate. So the opposite of imagining this like calm and safe place is very similar. We'll have them pick a memory and really enrich the five senses. So have them say what it smelled like, what it looked like, what it tasted like. So it makes it more accessible and implemented effectively. And so that can be a really fun activity. And you can carry this place wherever you go without anybody noticing. For those who might start with those more child-friendly mindfulness activities and don't want to, again, like start immediately with the attention to where it feels like the pain is originating from or experiencing, then you can use breathing as a positive sensation prompt. Obviously, if the pain is related to like the lungs or breathing, then that might not be the best idea. But I often have them attend to the inhale and exhale in an area that feels most pleasant or comfortable to them as they breathe. So it could be their stomach, could be their chest, could be their nose. Really have them lean into the sensation. Again, it's a nice and easy way, knowing that you're just communicating messages of safety to your brain the best way that you can. And you're engaging in safety reappraisal and positive affect induction. You can be thinking about something positive. You could be thinking about your version of the blue Smurf. You could be telling yourself that, this is a great way to reflect on your body in a way that feels safe, that you're doing your body a favor and enjoying those physical sensations while giving your brain the practice to pay attention to the body through a lens of safety. You're sort of paving that alternative route, right? So just the act of enjoying and focusing on breathing is the best thing that they can do for their brain. And so a lot of times they can, hopefully they will feel like that is something they can feel pride in, even if they immediately push back and be like, but it's just breathing, right? But really that is something that they're doing that is training their brain to think differently. There might be some barriers that come up. These are some common ones. Having an ulterior motive, like I'm gonna eliminate this pain. That's that intensity. That's that pressure. Remember, we're not caring what happens to the sensation. The sensation is not dangerous. It's not a threat. It doesn't matter what happens to the sensation. If it intensifies, that's okay. If it subsides, totally fine. If it moves around, we're just following it. We don't want to track it with intensity because it's not necessarily reflective of what's happening in our body, right? It's not an accurate indicator. It's just our brain's best guess. And giving permission to attend to sensations openly and curiously. Some clients will say, okay, well, what if my pain doesn't move? I wonder if in those cases that individual is having a hard time or has had a hard time letting go in general. If it's hard for them to sort of feel out of control, like not to hold the pain in a particular place because that's where they're monitoring it with intensity. Validate that, right? Oh man, I imagine that's super exhausting to control everything all the time. Like, see if right now, just for 60 seconds, you can give yourself a break and just let go. And then after that, we'll sort of tune back in and see what's happening, where it is, what that sensation feels like, how you would describe it. So they did the original Boulder back study for PRT. There has since been multiple more, but they randomized participants. Those in PRT participated in one telehealth session with a physician and 8 PRT sessions over 4 weeks. So again, this is not a long-term treatment. It doesn't have to be. Treatment did aim to help patients reconceptualize their pain as being due to non-dangerous brain activity rather than peripheral tissue injury. using a combination of cognitive, somatic, and exposure-based techniques. And then participants were also randomized to placebo, who received just like an open label subcutaneous saline injection in the back. And then there were also patients randomized to a usual care, just their ongoing routine. They found that 33 of 50 participants, so 66% of those randomized to PRT, were pain-free or nearly pain-free at post-treatment, evidenced by rating scale assessments. So someone had mentioned SUDS earlier, based on that, and fMRI results. Those randomized to the placebo were 10 out of 51 participants, 20%, which reported improvement, and 5 out of 50 participants, so 10%, who reported improvement, just randomized to their usual care. And gains were largely maintained after 1 year. So it did have some sort of like sustainability. So the conclusion is that psychological treatment focused on changing beliefs about the causes and threat of things like chronic back pain, which is sort of the foundation of PRT, may provide substantial and durable pain relief. I've mentioned this throughout today, but I do feel like it generalizes. It is consistent with extinction-based treatment approaches to anxiety disorders. It's been found that 85% of patients became free of panic symptoms following treatment focused on sort of reappraising their somatic symptoms caused by non-dangerous CNS processes like false alarms. And I've integrated into trauma, phobias, panic disorder, depression, and using that paved road example, using that psychoeducation about neural pathways can really be helpful in better understanding and managing stressful thoughts. So we're tapping into sort of the C of the CBT. People do report a significant psychological toll of pain, right? Fear of injury or re-injury, stressors of navigating the medical field, appointments, which isn't just the appointment, right? It's calling, it's sitting on the phone for maybe an hour and waiting to talk to a person that is going to hopefully find an appointment within the next month or two versus could be 6 to 8 months from now. That provider might not be available that day, might have something happening, might have to reschedule those appointments. You might need a scan before you even meet with a person to talk about that appointment. And all of these things are not just time and emotional resources, but financial resources. So it's a lot of stress. There is a distrust of the body, feeling of betrayal of the body. There can be some grief, which is, taps into that experience of depression, feeling more fatigued than normal, feeling more on edge than normal, feeling easily frustrated. You might have to shift your hobbies. You might have to pause or fully discontinue things that you were passionate about. And then having family and friends who don't get it. So when I think about signs of progress psychologically, I talk about, the interpretation of pain as being the first sign of progress, not necessarily how it feels. It's more the understanding of the psychoeducation. So measuring progress by response, not sensation. So are they responding to it on edge, feared, anticipatory, or are they more open? Are they more curious? Are they more willing to tune into it? Not necessarily, would I rate my pain on a scale of 0 to 10, and was it an 8, and now is it a 5? So reporting less fear during pain episodes, having sensations fluctuate without immediate escalation. And I get that in a very real way, like having a little twinge of something and being like, oh no, is this the start of a flare? Am I going to be stuck in this pain that's only going to get worse today, tomorrow, could be the whole week? I have plans for next week. Is this going to impact that? How do I communicate that to people in my life? What do I do? What should I not do? Having shorter duration of flares, bouncing back faster after tough days, increased willingness to move or engage. Someone said that they can really relate to that in the chat. Time spent worrying about symptoms. Worrying about symptom is attending to that sensation, even if they're not experiencing it with a lens of fear, which will likely increase the likelihood that a person experiences pain and that pain dial is sort of turned up. and greater trust in the body and interpreting its signals. There is something called the spoon theory. People use spoons as sort of these finite units of energy. Writer Christine Miserandino coined the term. She was at a diner with a friend trying to explain what chronic illness feels like. So she grabbed a handful of spoons to make her point. People are really responding to spoon theory in the chat. People who have chronic illness or chronic pain might refer to themselves as spoonies. So that's another way to sort of connect your clients with other people that might be going through similar experiences. The healthy people may have an unlimited supply of spoons, but people with chronic illness have to ration them just to get through the day. And I have a visual that you can use with clients on the next slide to sort of show them spoon theory. But it basically is now used as shorthand to explain how they're feeling as well as capacity day to day. So this is a visual of the spoons. Every day on a good day, right? And that's taking into consideration the day, the week before, good sleep, good diet, no stressful things in the past recently, no things that you're like stressed about in the future, the temperature isn't impacting you. Like maybe you have a full set of spoons, but if you have a high pain day, you might only have 3 spoons. Like all that stuff is impacted. It takes away the number of spoons that you have. And you have to decide, like, am I going to use my 3 spoons to either make dinner, take a shower, or go for a walk? You can't just like make a little dinner, like clean yourself a little bit and go for a little walk. Like it doesn't work like that. Each thing requires a finite number of spoons. We have to choose sometimes, and that can be really hard as the person experiencing the pain to like describe in a way that feels clear. But a lot of listeners have reported that this is a great way to sort of understand it and a great visual to use. So they might ask, instead of how you're feeling, like how many spoons do you have? Or they can report as the person experiencing the pain, like, hey, I only have 2 spoons today. Oh, that's a great point. Someone says my chronic illness clients report their spoons at the beginning of session to allow us to see how in-depth the session can go. So it's just really a great way to assess where they're at in a way that isn't, again, focusing the language and the impact on pain or on discomfort or even on physical sensations. We're talking about spoons. Like how many spoons do you have, you know? I do encourage my clients to share with other people in their life, but I also validate that being vulnerable and sharing tough stuff can be really uncomfortable. Their pain is valid, right? They shouldn't have to carry it alone. It doesn't make them a burden to share that information. They're not placing a burden on a person by sharing, they're removing a burden on themselves by being open about it. And very commonly, they have a little pesky voice in their head that might say something like, oh, well, I don't have to share because mine's not that bad. Other people have it worse. I don't want to seem like I'm always complaining. I don't want to be a burden. And acknowledge the fact that it's easier to say I'm fine or I'm better when someone asks how they're doing or feeling. And they might be better. They might be better than yesterday. They might be better than the week prior. They might be better than the last time that person asked them that question, but they might not be feeling fine, right? So the nuance of that is something worth exploring with clients. I often do sort of a pre-share prep with my clients, building insight into all of these things, maybe doing some role plays, process beforehand. It really allows for a better organization of their thoughts of what they want to say, checking in about feelings that arise. Even if they have a spiel, they might, to share it with certain people, might find vulnerability in different sections. So doing a role play and imagining what it's like to share with them could be a good way to find out like where their voice might crack or where they find themselves getting a little teary or maybe a little more frustrated. And once they recognize what might be more difficult to share, we can prepare better. And there's not just one right way to do this. Again, I'm open to handwriting, typing, voice memos, doing something in the car. Lots of different ways to prep for this. I wear different color bracelets for the family to look at and know ahead how much I'm capable of in that moment. I love a bracelet or a scrunchie or an elastic. I use it a lot with my high risk clients too, to communicate like where in the crisis they are. Like, are they having these thoughts? Are they really struggling? Do they need someone just to sit with them and silently support them? Do they need intervention? So utilizing again color or items that you can use again because maybe you don't want to talk about it. Maybe talking about it literally hurts. I have some nerve pain in my jaw, so sometimes talking is painful, and I don't want to. So having something like a scrunchie or an elastic or a bracelet is such a great idea. Um, Someone asked, what if the client is no one that they can share with or has been deserted by family members due to chronic pain situations? So hard. Validate how hard that is and see what they're looking for in support and utilize things like the Spoonie community, like the Blackout Poetry community. What is it that they enjoy doing? Are there opportunities for them to do that, like player pottery or rock climbing or going to a book club where they can have some foundational things in common with individuals that they can sort of build some support? Do they find religion to be supportive? Is there one person that's not a family member that they have in their life that they can trust? And I think if not, then part of the work is really finding that person. Because I would want all of my clients to have at least one identified individual in their life that they feel that they can connect with and share some of this information with outside of myself. And you can sort of model the benefit of talking about these things in the therapy, like within the therapy context. But yeah, I would definitely work on that, but validate how hard that could be. Um, yeah, people are saying feeling alienated or isolated due to the inability to be mobile because of the pain and feelings of missing out. Absolutely. Um, I think in terms of reputable or safe online communities, like there's the different apps that I like Think Ladder, like Flowly. There's something called Achy Penguin for younger individuals, which I love so much. There's a new app called Nirvana that I've been like exploring a little bit that uses a lot of like pain neuroscience and like PRT style, like the modality, the interventions that they're using. And so to this point of this person online, this person in the chat, there are plenty of places depending on what they're looking for, depending on their diagnosis, depending on even just like going to PRT, like their Instagram. All these places have like Instagrams and social media options for virtual meetings, for hybrid communities, that they can connect with. And maybe part of the work is finding that with them and doing a little bit of like in between work. Yeah, I will in the chat type out Think Ladder, Slowly, Nirvana, and Achy Penguin. There's really good apps that I like. I'm also reminding my clients when they're preparing to share that they can experience one more than one feeling at a time. We might like dip into a little bit of DBT. They can say, I'm not physically feeling great, but I'm really glad to hear from you, right? A lot of people in the Spoonie community might have a fear of voicing their experiences for the fear of not being invited anymore, right? Like I have to like do the I have to communicate that I can't do this. And the more I say no, the more I'm afraid that I'm just not going to get invited anymore because they're going to think, oh, well, this client is going to say no. So I might as well not, invite them. Communicating that straight up, I think is beneficial. But you can say something like, I'm not physically feeling great. I'm really glad to hear from you. Or if their needs are, I'm actually really hurting today. And so like, I'm just binging Netflix. That's what I'm doing. Can we talk later? Can we talk another time? They don't owe anybody an immediate response. There's pressure to like see notification and like get on it right away, and like fear that if they go radio silent, which we'll talk about in a bit, like how that might impact the dynamic. But it's okay to rest and like get some energy, decide what you want to do, decide what you need, see if the flare fades before you respond. And also, let's say they do start talking or sharing and they do find themselves being overwhelmed. They can stop. They can say, no, I don't want to answer that question. That's a complete sentence. They don't need to justify, they don't need to over explain. If the person who's listening is having a hard time with that, they're the ones that need the work. And sometimes I'm not working with the client that's in pain. I'm working with a supportive individual in their life who's coming in struggling on how to support their person in pain. So I think that these are, all good things to keep in mind. Someone asked, are there ways to increase a therapeutic approach and minimize the use of narcotics? I think the idea behind things like therapeutic interventions for chronic pain, period, CBT, PRT, just like mindfulness-based interventions, the goal is that by utilizing these more psychological-based interventions, we're able to reduce the frequency, intensity, and duration of their experiences of pain, therefore requiring less medication to treat, tolerate, and long-term manage the sensations with medications, with narcotics, with opiates, with things like that. So I think using it is certainly in conjunction with, and then perhaps using it in replacement of those narcotics is the goal of pain psychology. So for listeners who come in, for the supportive person, right, I want to validate them too. I want to say that it's pretty normal to have someone share something that's happening to them, right? Open up about their tough stuff, and then to want more information, to want all of the details, to ask a lot of questions. And some people might find it really helpful to share everything, but it's kind of case by case. And so it's important to let the person who's sharing take the lead. And there's options, right? And I might role play this with them. They can always ask. If they have a question, if they want to know more, they can certainly advocate for that. But then there's two options, right? They might say yes. And then if the person who's sharing says yes, I always encourage the listener to remind them often that if at any point during the conversation, the sharer is feeling drained, they can just talk about something else or simply end the call and talk later. It kind of gives them permission, something that they might not do without that because they're trying to people please, because they're anxious, because they've just prepared for this. But to have someone sort of acknowledge like this is a lot, this is tough stuff, this is vulnerable, this might be causing an increase in painful sensations. If at any point I start to notice that you're having a hard time, or you do, and I can't see it or hear it, like feel free to say you're done and to change the conversation. Like, that's okay. I want to listen to what you have to share. And if we don't want to talk about this, I still want to be in your company. And if they say no, you have to honor their feelings. And that needs to be immediate. You can ask them what might be helpful in that moment. Is it a new topic? Is it a funny distraction? Is it listening to music together? We're talking about the magic of music. Those are all really important things. Lots of people have experience with people pleasing in the room. Having to go to a pain clinic can be a very traumatic experience itself, certainly, for all the reasons. After a person shares information with a listener, I encourage them to do their own research. It's not the responsibility of the person sharing to fill that individual in completely. And it feels so good to give someone a diagnosis or share about a medication or a procedure that was recommended to them, and then have the person who received that information not put all of the responsibility on that individual to like obtain more information and answer their questions, but to go off and do their own research and then come back and say, oh, I was reading about this and this makes a lot of sense to me. I'm wondering about this. Did you ask this question? Maybe something to write down. I'm happy to accompany you to your next appointment. Learning do's and don'ts. And this is really great to do as soon as possible and not in a moment of crisis or during a flare. Things like what meds do they prefer in certain situations? What foods and drinks help? And which foods and drinks hurt? Do they prefer ice or heat? Do they have a favorite movie, a favorite song to listen to, favorite pajamas or clothing to wear? What is the spot in their home that feels most comfortable to them? Which lights should be on? Which lights should be off? Knowing all that beforehand can allow for the person that's in pain to sort of take a step back and just channel whatever resources they need to make it through that experience without, again, being responsible to direct or allocate or delegate like things that they need in that moment. They're overwhelmed in that moment. It's so nice and so helpful to have a person just like bring you what you need, like this medication in this colored container. I just need one. Bring it with like lukewarm water because cold water is gonna be too cold. Please get my heat pack. I like it microwaved for 1 minute and 30 seconds. Put on this song, like bring my headphones, turn off all the lights, just like having that plan. Someone saying a safety planning for a pain episode. I really like framing it like that. Can be so helpful and also so validating that they like are supported. And that brings us sort of to 3 and 4. Like the number 2 is something that a supporter or listener can do, because even if they're a doctor themselves, they're a very own pain psychologist partner, if they're not personally living that chronic pain, that chronic illness, they won't truly understand what it's like. And that's okay. Like that individual can still be such a supportive person in the client's life, even without that lived experience. So, sort of highlighting that no matter what they do, they'll never truly be able to understand. And that doesn't diminish the positive impact that they can have while they support their individual. Someone said, I've learned that stress of actual or perceived can induce pain. Absolutely. That's the direct impact of our the psychological component on the biological component of pain. And also work on acceptance, both for the sharer and for the listener, that sometimes there's nothing that can be done, right? You can have a safety plan for a pain episode, everything can be done right, and it's still going to hurt. Like that flare might still linger, might not be diminished or eliminated immediately. And being realistic about that, and hopefully it's really validating for both parties that there is this shared frustration, that there's not always a quick fix to the problem. So working on using sort of that acceptance and commitment therapy for that acceptance. Someone said, I have a lot of clients using medical marijuana, but this is something that I was informed that there was nothing medicinal about it. Do you know if this is something that's beneficial for chronic pain? Well, I certainly have many clients who utilize medical marijuana for pain management, and it's certainly like one of the criteria that could obtain you. I mean, when they were having cards, like a medical marijuana card for being eligible for medicinal marijuana or medical marijuana. So yeah, I think it's in a lot of ways designed to impact a person's experience of discomfort. And a lot of people have found it to be very beneficial. So it would be sort of in their safety planning. But not everybody benefits from that. For some people, using marijuana increases their experience of anxiety, which might turn up the volume on their pain dial. And so it's not really helpful. Or a lot of people who experience pain and are not quite ready to track those somatic symptoms through a lens of neutrality or safety might be redirected to the physical sensations of being high and feel really overwhelmed because they don't really have any control over it. So they might feel those like sensations, like the hallucinogenic properties, and be more overwhelmed, which again might negatively impact their experience of pain. So I think it is case by case, but certainly something worth assessing their history of active and like curious experience with medical marijuana, and just having open conversations about why it might be beneficial, why it might not be their first line of intervention, and then, ways to trial and error it in a really small, sort of like monitored way, just to see if case by case it's helpful for them. So we come back to radio silence. That's for individuals who have sort of advocated for their own needs, who haven't responded right away, who have been unable to attend gatherings and invitations, but it's really stressing out about how long it's been since they've reached out, wondering if their people are upset, hoping no one's noticed, and if they have it, it's not a big deal. So to those individuals, I say, okay, to cut ourselves some slack, right? They're really going through it. And ultimately, the client is the expert on how they're going to get themselves through this painful experience as unscathed as possible. But I also encourage them to reach out to those people. Like, they did choose them for a reason, and I want them to give them a chance to remind you why. And again, that might be to the earlier points of what if there aren't many social supports, or which social supports do you choose to share this information with? That could be part of the pre-share preparation, identifying individuals that feel safe to, have these conversations with. And again, you as the therapist might be the sort of foot in the door to these conversations that will be held outside of therapy. Someone said part of safety planning, pain safety planning discussion can be about the immediate reduction of spoons, and that's okay. Yeah, that's a great point. Self-preservation versus laziness. And that alone is just language, right? Like reframing that it's not laziness, but it's survival and things that we need. Like, we have to be mindful of how many spoons we have and how many spoons every action requires, and making a choice. And that's where some people do end up in bed, but eventually want to replenish their spoons, or wake up the next day and feel like they have a couple spoons and they want to walk through that step-by-step process of getting out of bed. So absolutely talking about those things. It's a great point. And then again, not just the share, but the listener, to those waiting in silence, wondering what's up with the unread text message that they sent, or worse, if the text message has been read that's gone unaddressed, I remind them of this, right? Obviously, their feelings are valid. They should feel those feelings. And it's okay to communicate with the person in pain effectively, right? There's ways to do this appropriately and ways to do it in ways that are quite ineffective. But that person is not a burden for also having needs in the relationship. Like, their wants and needs should be taken into consideration, should be communicated, but there does have to be some like give and take when you're navigating a dynamic. It doesn't have to be a romantic relationship, just like any relationship with a person in pain. So everybody should be able to communicate their needs, and there's certainly ways. And maybe it's a circumstance where both parties come into the office with consent and you sort of moderate and mediate that conversation. But there's so much room for role play and pre-preparation. But also let the listener know everybody gets overwhelmed with something at one time or another. So be patient, right? We have to have patience with our people. And when patience has run thin, because it will, because that's real life, it's okay to reach out to the person who is in pain and just let them know that you miss them and you want to dedicate some time to reconnect. Ways that you can do that effectively is just saying, hey, thinking about you, period. You would say, hey, no need to respond. You were just on my mind and I wanted to say hi. Um, like hoping all is well, here to listen if it's feeling hard right now. Would love to find a time to connect if and when you feel ready for that or up to that. Um, can I bring you anything that will like make your day better? Like I can come to you and I can drop it off at your front door or like leave your door open so you don't have to move, but I'll just drop it off. There's no requirement for us to hang out or you to listen to what's going on with me. I just want you to know that I'm here. I'm not going anywhere. I'm a resource for you. Um, a lot of times they're feeling that way. They're just not sure how to say it. And sometimes well intentioned, they might say something that puts a lot of pressure on this person in pain that might be people pleasing, that might be anxious, and not mean to. So, like, kind of giving each party permission to show up as they would like to and work through these conversations effectively. So that's it. I would recommend, I mean, this is where all the material is from, but certainly, again, Adrienne Lowe, Why Do I Hurt? A patient book about the neuroscience of pain. And then Dr. Rachel Zoffness, she's a pain psychologist. She has a workbook for adolescents and a workbook for adults that you can utilize in session, which I do. I love both of them, and her website has just an amazing collection of resources. So I would highly recommend her. She's currently like pushing into medical schools now to get pain management as something that they're just learning as they're being raised in the medical field, which I deeply appreciate. So I'm seeing a lot of appreciation. Thank you so much. I appreciate all of you for being here with me. Any questions in the last few minutes before I turn it over for a wrap up? Here, I'll stop sharing my screen. For anybody that has any interest in learning about pain reprocessing therapy, you can go to painreprocessingtherapy.com. They have a free 1 hour like overview training that you can get a CE for, which is really nice because it's free. And also, then they have like a big training as like a beginner that's sort of a month-long intensive, and then there's opportunities for like groups and sharing that you can do, but also you can find certified PRT providers by state so that you can refer out if you'd like or collaborate. And if you have any questions for me, you can feel free to contact me.
I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post-test. If you're looking for more CEs, check out our unlimited plan. You will get unlimited access to 150 plus ASWB and NBCC approved continuing education courses for one low annual fee. We're always adding new courses. Did I mention we also have 5 free CE credits available too? Check it out at agentsofchangetraining.com.